Okay. Hello, everyone. Today is pretty special. We have a really interesting panel on social determinants of health, which is all the things kind of around the human body that informs what happens to the human body and inside the human body. I'm Keerthi Vedantam. I'm a bioscience and health reporter at Dot.LA, and today I just want us to have a really honest conversation about health equity and AI. So we've got three wonderful panelists today. I'll have them introduce themselves. Ardy, would you like to start?
Sure. Thanks so much, Keerthi. And thank you to AI Live Summit 2021 and Todd for having myself and the other inspiring panelists on here. My name is Ardy Arianpour. I'm the CEO and founder of Seqster based out of San Diego. We are a healthcare technology company, SaaS-based. We put the person at the center of healthcare, disrupting all their EMR, EHR data, baseline genetics data, wearable continuous monitoring data, as well as bringing together social determinants of health data and lots of other different types of data. So really excited to be on this panel and share what we've learned within the space.
Awesome. Lisa, why don't you go next?
Sure, thanks. And thanks to the organization for having us. It's really exciting to be here. I'm Lisa Lines. I'm a senior health services researcher from RTI International. RTI is an independent nonprofit research institute, and I've been there since 2009. My work involves the intersection really between medical care and public health, so population health and access to care, quality of care, and costs of care, and do a lot of work in cancer and also in social determinants. So I'm happy to be here. Thank you for having me.
Great. And lastly, Paul.
Hi, everyone. I'm Paul Chung, and I'm a general pediatrician, and I'm professor and chair of the Department of Health System Science at the Kaiser Permanente Bernard J. Tyson School of Medicine, which is a brand new school that is aiming to try to innovate in medical education in ways that change the profession. Prior to that, I spent most of my career as a health services researcher and also involved in federal child health policy. My main areas of interest have been what we call childhood determinants of adult health. So really thinking about the few key areas in childhood that have long-term, lifelong impacts, and especially in kids who have either social or medical complexity. And so I work in areas like complex care programs and primary care redesign, but I also work in areas like educational environments and early childhood development and adverse childhood experiences, juvenile incarceration, child poverty, and other areas like that as well. So really happy to be here and glad to be invited.
Awesome, great. So let's just start with the basics right here. When your average person thinks about healthcare, they probably think about, going to your doctor and getting a checkup or a surgery or being prescribed drugs. What exactly are social determinants, and what kind of role do they play in our health? Lisa, do you wanna start?
Sure. The World Health Organization says that social determinants are the conditions in which people are born, grow, live, work, and age. And so you can think of the social determinants as, things that really affect healthcare outcomes that aren't anything to do with actual healthcare. So this includes things like educational attainment, educational quality, access to healthcare for sure is a socially determined thing. Social and community context, so like community health and well-being and healthy behaviors, bias, stress, trauma, those adverse childhood events that Paul was talking about, and justice, crime, incarceration, and then also, of course, economic stability, so food security, access to healthy food, poverty in general, sort of poverty, and also inequality, income inequality, and employment status. And then there's all the things around the neighborhood, so like housing, crowding, structural health, environmental quality, transportation, access, infrastructure, all of those things. And then policy. Policy makes is one of the social determinants as well.
Paul, do you have anything to add?
Not really. That's beautifully stated. There's this kind of old public health paradigm, which is that if you have a pie chart of the stuff that actually matters for health, medical care only accounts for something like 10 to 20% of that. And we have this, I think, cultural tendency to just fixate on medical care, like that's going to solve all our problems. And the reality is that medical care is going to solve very few of our problems. And if we actually care about sort of health and health more broadly, then we're going to really have to take into account the social determinants, and not just take into account social determinants, but actually prioritize them over what we traditionally consider to be medical care. And that requires a huge paradigm shift in terms of sort of all of our innovations, technology and otherwise, moving forward.
Wow, 10 to 20% seems, I guess, bleak, to put it lightly, given our level of healthcare spend. So, okay, when we're talking about social determinants, right, we're talking about things that, I mean, realistically are not under a doctor's purview, like making sure you have access to quality housing, making sure you have good education. I guess, like, what role realistically can, I guess, a doctor play in all this? Like first, I guess let's first start. Are healthcare workers trained in how to use population health for acute care?
Not at the moment. I mean, I think what you said is interesting. And I maybe Ardy should have a chance to speak as well. But like one of the prime purposes of our school, this new school, is to try to introduce different types of training that are focused on things like population health, that try to answer exactly that question that you've asked, which is sort of what is a doctor's role in a new type of healthcare environment that goes well beyond sort of what our traditional training is, and how can we help without stepping into things that we have zero expertise in and will just make worse. So it's a really critical question. It's an unanswered one, but it's one that I think a lot of people around the country are trying to figure out.
Yeah, and I think there's a couple things to add to that. I think Lisa really covered really, really nicely what is social determinants of health. It can get really confusing. It's all the other data that's not really the medical data, right? But there's a lot of data that's being captured, and there's a lot of data that's not being captured. So think about it like your zip code, right? We can look at Seqster, at a cohort or observational study, and put in a zip code, and we can tell you exactly like how and when and how much care is happening during, that geographic region. I'll give you an example. If you put in Stanford zip code, most people around that area are actually really healthy. If you put small town in Louisiana's zip code, they're not healthy, because it's the underserved community. And this is where health equity and social determinants of health kind of come into play. And just like Paul and Lisa were alluding to, it's about the economic stability, community access to quality care and health care. That access to health care itself in most of our country is, really hard unless you live in California and New York, or maybe Texas. I mean, but most of the states, even if you're in Hawaii, I mean, I'll give you an example. Even myself personally, I was there 2 years ago, right before the pandemic, for New Year's, separated my shoulder, and it was so hard to get care in Hawaii, even though Hawaii is not like another country. But if I was in San Diego or in LA, and I can go to UCLA, or I can go to a Kaiser, or I can go to a Providence healthcare system or whatever, and I have health insurance under PPO, then I can get that care right away, and for prevention or anything within an emergency. So I think that access to healthcare and a lot of other types of data, which are known as SDoH, for social determinants of health, come into play. It's not just one data piece, such as your lab data or your genome data or your wearable data, But when you combine social determinants of health data along with all of the other metadata and medical data, this is where we can move the needle on population health and population analytics. And then to finish off your question, Keerthi, on, do health systems really utilize this stuff? Do doctors and nurses even know about it? They don't. Only the innovators really know about it, to be honest with you. So, Paul is an innovator, and that's why he's doing the great things he's doing. Lisa's an innovator, and I'm a wannabe innovator, I guess, because I founded a great company in 2016 that's doing amazing things for patients. But at the end of the day, healthcare moves so slow. There's so much red tape. And to get nurses trained, physicians trained, divisions trained, and having seamless software in place in order for that all to work, there's a uphill battle there.
So my PhD is in clinical and population health research, and it's from the University of Massachusetts Medical School, and that school is very unusual in having a population health degree focus at all. But even so, health systems are pouring billions of dollars into trying to address social determinants right now. And it is an open question still whether that's the right way to go. But it is, it's something that I think a lot of health systems in particular are very aware of. If they're being paid based on the taking care of their population, their entire population, they have to address social determinants, or else their outcomes are going to look terrible. And that's one of the things that that I've been studying the last few years as we've been transitioning more towards value-based care and paying for value rather than paying for individual procedures and just widgets. That's where I think we're starting to get some traction around this issue.
I do want us to touch on, value-based, payment models for providers. But I guess first let's talk a little bit about, social determinants of health. How, accurate are they? Like, can we actually reliably say that if you don't have access to stable housing, that does have a direct correlation to your health and well-being?
So yeah, we've spent a lot of time around that, and you can correlate that as long as you have a 360 patient view of that data on a patient and on that population. So if you don't have that, then it's very hard to actually take a look at. When you superimpose, let's say, the medical data on, let's say, housing or income, economic stability, you can actually see in certain areas, for example, in Beverly Hills, most people can get really good care because they have money and they live in a great area and they have access and they're educated and all those other great things, right? So it's very, very easy to point out. What's difficult is when you try to do it at scale. And that's a whole nother conversation. But the scalability of that gets a little bit more tricky. But there are, tools and softwares out there that allow that sort of data curation. Mm-hmm. However, you have to bring the people and the consents of the data in order for that to happen.
So I think that I agree with everything Ardy said, and I think that the data linking social determinants of health with health outcomes is indirect but strong, right? So we just published a paper this week that showed that, for instance, states that spend more money on child and family social benefits have fairly dramatically lower rates of child maltreatment when you control for all these other factors, right? Mm-hmm. So there's a lot of this type of evidence that is out there. I think that I'm sorry, I just got distracted by Daniel Kim's question. And
And
it's a really important question. I'm just going to quickly turn to that. Is that okay? Yeah.
Yeah. Actually, I think this is pretty on par with exactly what we're discussing right now.
Great. Yeah. So yeah. Go ahead.
I don't know if everyone can see the questions, but Daniel Kim is asking for SDoH data to be useful. Does it need to be linked at an individual level with patients?
And the answer to that is there are a couple of levels of data, and Ardy alluded to this when he talked about scale. There are a couple of levels of data that are all equally important. You have to be thinking about what types of interventions you're imagining, right? So there are interventions that you can make at the patient level. There are things that you can do to actually help your patients. And for that, you have to have individual level data. And without that individual level data, what exactly are you doing? But there are bigger at scale investments that you also need to make in communities and systems. And for that, the individual level data is less important. And what you really need is really good, high quality aggregated data. And so you need to be able to do both at the same time and do both well. So it was a great question, and it really goes to the heart of a lot of what of the big data questions surrounding social determinants of health are.
Yeah, they feed off one another, actually. Paul articulated it perfectly, because you can't just have social determinants of health data and, give answers and have insights. You can't just have medical data and say, okay, you know what, I'm going to be able to find that answer. If you're looking for the answer, this is where that data linking is so important.
If I could jump in, I actually think that there's a long and rich literature on the effects of neighborhoods on health outcomes, way separately from individual outcomes. So your own individual income obviously matters, but then the incomes of the people around you also matters. It has a separate and independent effect. So yes, when we're looking at population health, I think it's important to link to individual level data, but we can also learn a lot just from looking at community level data. We can look at community needs. We can look at where resources are necessary to be invested, and where you have those kind of gaps. But it's really important, I think, to have the right level of geography available. So county level data or averages are just almost useless. I mean, think about LA County with 10 million people. You have an average across 10 million people. It's not very informative. If you can get down to the 9-digit zip code level, which is census block group, that's where you can actually start to see, maybe that's around 1,000 people. Or one level up from that, the census tract level, that's about 4,000 people on average. That's where you can actually make much more informative analyses happening.
So I also think one thing that we're missing that we haven't talked about is the fact that, a lot of the data that is existing is on white Caucasian males. And we're missing that diversity of data. We're missing, if you take even just like, any type of research study, it's missing Asian data. It's missing, South American data. It's missing Middle Eastern data. It's missing lots of different types of diverse data. And that diversity of data, if you're talking about social determinants of health within the United States versus globally, in various different countries, third world countries and things like that, there's a lot of correlation there from the data pieces from, let's say, countries in Africa that don't have any access of anything to care versus, Germany or France. And I think that's really of interest, obviously, to population health as an overall, because we can learn a lot about, different cohorts if we have diversity of data and really concentrating on that health equity and the underserved communities. That's where really, I think a lot of concentration is being poured in now within health economics outcomes research, especially on the commercial sides of things, within pharma companies, payers, providers, and so forth.
So, we're talking a lot about data here, and this is kind of where AI, sophisticated machine learning, comes in. And this is where, things actually get a little tricky for us, right? Because there's a very obvious need for this data and to understand this data. Let's quickly start with, first of all, who is supposed to be collecting this data? And then on top of that, who is supposed to be using the data? Because this isn't just doctors and hospitals, right? We're talking about truly a really holistic, I guess, experiment here. So, Paul, do you want to start?
Sure. I mean, it's pretty clear when we're talking about this type of data that you can't have a single source, right? So there's just too much data and too much variety of data that needs to be collected at both the individual level and at larger population levels. And so it has to be the data collection system has to be one that where you're talking about a lot of shared data across a lot of different sources and a lot of different players. And that kind of has to be built into the system, because it's really difficult to imagine a situation where you'll be able to do some really high quality analyses of social determinants without that to begin with. And I think that just raises a lot of important questions about the complexity of the whole process, and really thorny issues about that range from like privacy and ownership all the way up to sort of a tragedy of the commons situation, where everybody is like, but it's a problem, but it's not precisely my problem, and so I'm just not going to worry about it. And so and then there's the sort of the bigger issue of sort of the black box of AI. I mean, it's not entirely black box, but there are aspects of it where we know already from the medical literature, we know that that use of AI algorithms has been associated with increases in with unintentional increases in racial bias in terms of medical care and things like that. So we all of these things are sort of layered on top of each other in terms of the complexity of the mission.
Right, and I think the fact that a lot of doctors don't necessarily know how AI comes to a specific decision. What happens if a doctor disagrees with the AI? Where's the recourse there? What happens next? Ardy, I want to talk a little bit more about Seqster, because I want to talk a little bit about how you guys collect the data, because you Seqster does a lot of stuff on personal data as well, but also taking into account community health, social determinants of health. Can you talk about that?
Yeah, so we pioneered patient-centric interoperability. I actually filed the first patents in 2016 on a multi-generational health record, because I wanted to bring my grandmother's data, who's suffering from Alzheimer's at the time, my mom's data and my data into a longitudinal health record. That's how I founded the company. Before this, I spent almost 17 years in clinical diagnostics. I was one of the first people to be whole genome sequenced. And when I got my whole genome sequenced back in 2009, which most people didn't even know what that was at the time, it didn't really give me, insights as to, what my overall health situation was. For sure, it had great markers for certain things. For example, my mom's a breast cancer, survivor. And so we have certain genes that are passed down from the hereditary side for my family. But at the end of the day, we really wanted to create a longitudinal health record. And I really believed that, you own your data. Lisa owns your data. Paul owns his data. Every single individual on the planet, 7.7 billion people, should own their data. But why is it we have dashboards to see, how fast we're driving, how much gas we have in the tank, and why is it we have systems like Mint.com where you can bring your Wells Fargo, Bank of America, and student loans in one place and you can see your net worth? Why is it no one has ever, thought about really creating the Mint.com of healthcare? And so that's what my team and I set out to really do. And we didn't think that we would actually get there, but we were at first backed by Bill Gates and Boston University. And that was because of our Alzheimer's disease cohort project that we did. And then we created the Seqster research portal for pharmaceutical companies. And then we got backed by Takeda Pharmaceuticals, as well as 23andMe and United Healthcare Group investors. And then from there, we really started working on 24 different distinct use cases where we're able to, empower individuals to collect, own, and share their data, any data source. And this isn't a dream. It's deployed. It's out in the marketplace. We seek out health data upon the individual's request and consent. The traditional way of getting medical records is through, a fax, or it takes 30 to 60 days from a hospital to actually pull records for patients and interventions together. But with Seqster, instantaneously, within milliseconds, we are connected to every single EMR system out in the country, from Cerner to Epic to Practice Fusion to Meditech to eClinicalWorks and so forth, Allscripts, you name it. And then we have 55 million genotyping, sequencing, exome, files within the database, as well as 400 plus different wearables. And this sounds like, oh, well, you guys are just an aggregator. We actually had to do the heavy lifting on the engineering side. We standardized and harmonized all the ICD-9 codes, all the ICD-10 codes, as well as if you just take, let's say, an Apple Watch and a Fitbit. Well, I'm not wearing my Fitbit, but two different watches. But, one says biking, the other one says cycling. So, in order to bring a longitudinal health record, we spent $30-something million into the platform from our partners.
Cleaning up, you also have to clean up all that data too, right? And that's a major resource. I guess it's kind of a time suck a little bit for really important data. At least I would also love to hear from you about this subject, because I feel like that's kind of where, Seqster is doing this, but that's sort of where a bit of the rub is here, right? Like, data, it can't come from one place. It shouldn't come from one place because then it might not be diverse enough. It might not be accurate enough. But also, because it's not coming from one place, there are very few standards for how to actually put it all in one location so we can use it.
Well, there are standards, and I think we, over the past 2 years, RTI has been working on a project to bring together data from all the agencies, CDC, Census, Department of Transportation, USDA, EPA, CMS, FBI, HUD, and then a bunch of other private sector sources of data on social determinants. So we've been doing something pretty monumental in terms of pulling together all of these data and then using random forest algorithms in each of the 50 states and DC to understand, based on this database of over 150 different social determinants, how much of the variance in life expectancy at birth can we explain from census tract to census tract? We've now completed that work and have models for all 50 states and scores based on the models that tell you what percentile your census tract is in relative to the rest of the state in terms of social determinants related to life expectancy at birth, which, it's a vital statistic that really is something that countries use country to country to sort of compare how well we're doing population health wise. So it's a core, outcome measure, but we've also looked at infant mortality and drug overdose deaths and COVID-19 mortality. And in each case, trying to understand how much of that variation can we explain with social determinants. And it is a massive effort. So I noticed in the chat, we had a question about where do we obtain these social determinants data sets from, besides pulling them from census data. So yes, if all you need is census data, there are R packages. There's a package called Tidy Census, which is great for pulling in census data using an API. We have a hybrid API download approach at RTI, but there is a database coming from the Agency for Healthcare Research and Quality. It's a zip code level database, so not quite as fine a geographic detail as we might like, but it is at least completely free and available. They they've done the hard work and heavy lifting at the zip code level anyway. So ARC is a good source for that data, but there are others. I highly recommend a few different sources of data. Policy Map is one, and I want to also mention the Opportunity Atlas. That's a census project and a Harvard partnership that they've pulled together some really great longitudinal data looking back 1978 to 2015, looking at outcomes for people born in various census tracts. So lots and lots of data out there.
So I can't pass this up. I mean, I just want to emphasize that the work that Ardy and Lisa are doing is unbelievably important. I mean, they're approaching the same problem from two different perspectives, but each one is incredibly important, and it's the way it has to go. It's the way the data has to go in order for us to have any hope of solving any of these problems. So the stuff that they're describing, I mean, I'm so excited to just sit here and like listen to this stuff, because I'm seeing the future, and I'm seeing 10 years down the road, 20 years down the road, when we're going to be able to really use this stuff to massively improve population health on a genuinely scalable level. And that's like, I just want everyone in the audience to appreciate that what they're listening to is I think the future of social determinants of health data.
Thanks,
So let's talk about.
Thank you so much, Paul.
Yes, definitely. Let's talk about some of the applications for AI here. You know, when we're talking about population health, can AI be used, I guess, to with the right data sets, with robust data models? Can it be used to, I guess, predict how one's life will go, and we can, I guess, create interventions in the process? I would love to hear from all three of you, kind of about where technology falls in all of this.
Well, predictive modeling is my bread and butter. I think it's so fascinating, and you know, I always refer to it as machine-enabled learning, not machine learning, because it's not the machines that are learning; it's us. And you know, the whole black box thing. I mean, I think it's really important to start with a conceptual model, a really solid conceptual model, especially with this kind of work. And understand why you're putting in every single variable that you're putting into your model. But in terms of, you know, predictive accuracy, I mean, these models, I've never seen a perfect model before, but we did one analysis of infant mortality in Ohio where we could explain 99% of the variation in infant mortality at the census tract level. And that's the kind of predictive accuracy you can get out of these new approaches. Fancy math. It's really great stuff.
Oh, go ahead, Ardy.
Oh, I was going to say, yeah, 100% agree with what Lisa just stated. I go back to just the very simple premise of, you know, in real estate, they say location, location, location. I say data, data, data. AI, predictive models, predictive analytics, population health, all these amazing things, as Paul said, you know, that are happening now at one level, and they're going to be happening even more, cannot be valuable if you don't have the right quality, right fidelity, high fidelity data sets. And that comes from individuals. And you need to have a system, an operating system that can actually empower people to collect their data as well as share it in a secure environment. That's really, really important. And so I think, you know, the future has been accelerated because the pandemic accelerated digital health by, I would say, a minimum of 7 years, maybe even 10. So what the audience and Paul, Lisa, Keerthi, yourself, all of us are talking about here today on October 21st, 2021, 21 lucky number. It's as if it's 2031, because if the pandemic didn't happen, a lot of this wouldn't be possible. I think there's just a lot of funding and a lot of great innovation a lot of great research happening, and collaboration has to happen from the provider to the research to the entrepreneurs to the startups in order to really solve these problems. This is what I'm seeing.
So I tend to look at everything through kind of an equity lens, and so I just want to say one note of caution, right? Which is that innovations, just by the nature of being innovative and by the entire process of diffusion of innovations on average tend to increase rather than reduce disparities, because what you have is you have a set of early adopters, and these early adopters tend to be people with the financial, human, and social capital to be able to access these innovations. And what you end up with then is an even greater divide. And that is an absolute possibility and maybe even a likelihood for innovations on average that are coming through in tech and in other areas. And so if we're going to do this, and if we're going to do this right, then it is absolutely essential that the equity piece gets built in from the very, very beginning. That there should be a process where anyone who's trying to innovate in this area should be asking, okay, so how is this innovation? How are we going to plan this innovation, design it, market it, everything? How are we going to do this in ways that will end up reducing disparities rather than increasing them? And if you don't have a good answer for it, then don't do it, because you're just going to make things worse. And from my standpoint, that is the one caution I would have with all of this stuff, which is when you're envisioning this innovation, who are going to be the early adopters? And if the early adopters are a particular set of people who probably don't really need the help anyway, then it's the wrong thing to do. Not always. I mean, you can make these broader, bigger social justifications for it, but I just think we're at a moment in history right now where inequity in America is an unbelievably important problem and is getting worse. And we all have to kind of do our part to sort of stop it and to kind of say, look, we got to turn it around. And this is one of those areas where I just think it's really important to think about it always, to be thinking about these innovations from that lens.
Mm.
Yeah, I think, Paul, you bring up a really good point, and I this question might be sophomoric, but knowing kind of the systematic bias that can be created when we start using AI that we maybe don't even fully understand. I guess kind of in this situation, when we're talking about population health, how useful is AI compared to other solutions? And we can also discuss other solutions because we know housing is good. We know education is good. We know these things are useful. Truly, and Lisa, you brought up alternative payment methods as well. I'd love for you to discuss that. There are other solutions out there. I guess kind of, is AI a good, I guess, is AI something that we should maybe focus on? Or are there other things we should also be focusing on to kind of utilize social determinants of health in a more sophisticated, better way? Lisa, I'd love to start with you because you did bring up value-based care early.
It's just one tool. AI is just one of the tools in our toolbox, and it can be a tool for good or a tool for not so good. I mean, algorithms in general can have a lot of bias built into them, and that's partly about how we pay for care. I mean, the classic example of this is the paper that came out a few years ago by Obermeyer and colleagues, where they found that the traditional risk adjustment formulas and algorithms that are used in the sense that the risk score that you get out of them, if it's based on expenditures, right? You end up having a situation where less advantaged people, often people of color, have lower risk scores, but higher disease burden. And it's not being captured in the risk score because they have barriers to care. So they're undertreated. They have an underdiagnosis problem, often late diagnosis, and so they can be sicker with the same risk score, And so you end up with this situation where the algorithm is looking at the wrong outcome. It's not looking at health, it's looking at dollars, right? Because that's what we count in healthcare a lot of times. It's just the bottom line, right? So when we get at the money and we start to think about how we pay for care, we have to do it in an equitable way, coming back to Paul's point. And it's really important in my view, especially with value-based payment models, that these models take into account social determinants. Because if they don't, then what you end up with is providers who take care of better off patients, the patients in Beverly Hills that Ardy was talking about. Providers who take care of those patients look better on paper because they have easier patients in a sense. Patients with more access to care and reliable transportation and indoor air quality and all these things. So what we don't want to have happen with alternative payment models is a situation where providers are incentivized to only go after Beverly Hills patients and to ignore and leave out whole other groups of people.
So that's where the health equity piece is so important, right, exactly. As Paul was saying, yeah, and Lisa was saying earlier. I think another thing, just to wrap up on AI, look, I think what we didn't talk about, and I know we're out of time, is the dangers of AI. Hacking into health systems and accessing millions of patient, health data. Many health systems are vulnerable due to old systems, and we've spent a lot of time in this area. Many data breaches, have occurred, costing hundreds of millions of dollars. And, you need a solution that can bridge the gap between population health and medicine. And that's actually the patient. And that's what we really focused on with Seqster. And so, I go back to, I always say this whenever I give my talks, is I think AI is actually worthless unless you have the right data. And, it's like having, a Tesla car, but you don't have a Tesla charger. It's worthless unless you have a Tesla charger. So you need to be able to charge it in order to run it. And, that data is the oil for that. That data is the electricity for that. It's people. It's you. It's me. It's our families. And it's so important because it's going to affect your life one way or another.
Maybe another way of answering the question about do we need AI? One reason I think that we actually need AI is the beauty of economics, right? Is that it is the study of decision making in conditions of scarcity, right? And everyone forgets that second part, the conditions of scarcity. That drives everything, right? You have to choose. You have to make these decisions. And we can talk about things like universal basic income. Universal basic income, fabulous, wonderful, right? But as far as benefits go, it's a regressive benefit. It's one that isn't actually tailored in a progressive way to help those who actually need it the most, right? And so once you start talking about tilting and about targeting and about trying to take these scarce resources and figuring out how best to allocate them, and that's when you start to need much more sort of fine-grained data about social determinants. And the granularity of it becomes important because then you can actually start to make some really concrete decisions about who gets stuff and who doesn't. And that from a policy standpoint is the secret sauce. Is you have to be able to not just figure out who gets stuff, but you have to be able to figure out who doesn't. And that's where I think AI could ultimately, if everything works out, that's where AI could really make a huge contribution.
I quickly want to acknowledge this one question that we got. Data is the raw material, and its quality is as good as its sourcing methods. What types of data sourcing tools and apps do you find more equitably distributable? And I would also like to say, how do we know what exactly the bar for equitable, I don't know, data sets look like? Like what exactly does a truly accurate data set look like? If anyone is free to start on that question.
Lisa, this is all you.
Yeah, so that's a really, you know, it's a tough question. I mean, ideally, you know, we'd have all the data on everybody for everything, and there wouldn't be any gaps. You know, there are some Scandinavian countries that have that. They've got, you know, data on every citizen, and
Iceland, for example, does. Iceland, yeah.
Exactly.
And the MedMiji program in the Netherlands is trying to do the same. And absolutely, yep.
Yeah. So I mean, that's the ideal, is that you collect the same data on everybody and you have it standard, and no one's left out. Our current situation is we have more data than we should have on some communities because, for example, they're over-policed, and so they're overrepresented in the uniform crime reporting system of the FBI. And then there are other populations that we almost know nothing about, like the homeless population. I mean, it's incredibly difficult to gather good data on the homeless population. So, you know, it's our healthcare system is so complex, and getting good data into it is incredibly hard. So I don't know if I answered the question, but I gave it my best shot.
Paul, do you have anything to add?
Yeah, it will always be a work in progress. I think there's no other way to get about answering that question except for sort of incremental improvements as you find stuff and you test stuff out and it looks wrong. But I can't think of like a globally consistent way of just saying, okay, these are the rules and this is how it's going to be equitable. I don't actually think it's going to end up working that way. It's going to be much more piecemeal.
Yeah, my answer is you need a bottle of wine and a bottle of scotch, and you're going to argue what you're going to drink and what you're going to talk about. That is a complex question, and that takes an hour to answer. So that's my answer.
I encourage everyone to find all three of these panelists and read some of the work they're doing. It's truly amazing when we think about healthcare and how siloed it is, and using these tools that could genuinely be so useful, and then also thinking about at what cost. So thank you three for chatting with us today. I really appreciate this. This was such an illuminating conversation for me. And yeah, I guess we're good now. I think thank you all so much for joining us as well. Take care.
Great. Thanks so much.
Thank you.
Have a great day. Bye-bye.
Thank you, everyone. Bye-bye.